All right, first question. Define and discuss what a dermatome, myotome, and sclerotome is and how it relates to embryonic development. So, what's a dermatome? Anybody want to shout it out, dermatome, or have it written down? Definition of a dermatome? Yeah. Okay. Lateral part of the somite that becomes the dermis. It's some tissue that differentiates in the mesoderm, this thing called a somite, and there's a lateral part of it that ends up becoming your dermis. What also is significant about that dermatome as an adult, you know? Yeah. Okay. Yeah. So as that dermal area develops, it's going to be a certain region on your skin that is supplied by a specific individual spinal nerve. And so because those somites kind of develop down the axial skeletal region or longitudinal axis of the developing embryo, and little balls that are associated with each of your vertebral levels essentially. So that's how they're each associated with those specific you know, spinal nerve root. Okay. So that's good. Myotomes. What's a myotome? Gotta guess. The same thing, right? Kind of, but just for the motor system, right? So the group of muscles derived from one somite and innervated by a single spinal nerve. So it's the group of muscles. The dermatome is the area of skin. It's a sensory, by a sensory nerve. The myotome is the group of muscles that are associated and primarily supplied by that one spinal nerve. Okay. Myotome. And then a sclerotome. It's a part of the segmented mesoderm in the early developing embryo that originates from the somites, just like the other ones, the dermatome, myotome as well, but they give rise to the skeletal tissue of the body. More specifically, though, the vertebrae and ribs. Okay, so they're really developing the vertebrae and the rib regions. Your distal skeletal structures get developed by mesodermal differentiation, but not specifically as much from the somite. Okay, so this is just showing. This is looking down at the. So we're looking at the top of a developing embryo here. We're looking straight down at the top here. You can see these little somites developing, the little bumps along the axial longitudinal axis of this embryo that are associated with those vertebral levels, okay, of your spine. And so then looking, this cut right here is as if you're cut right down through the top of that. You're looking at it's really a horizontal cut through the embryo. Okay, so horizontal cut through the embryo. And then this is the somite. This is one of those little bumps. So this is the kind of the bump right here that you're seeing. And it's showing you a cross section right through this. So that's a high thoracic kind of looking level there, or cervical level, right through one of the somites there. And then if you look more specifically, that somite here develops into these three differentiated parts to it. The more lateral aspects, that dermatome, the more medial is the myotome, that more inferior, I guess, is the sclerotome, becomes a sclerotome. And you can see how this neural tube here that divides originally into a marginal and mantle layer, but then eventually into this motor plate or basal plate and association or alar plates, that's where then you get the differentiation of the gray matter, and you have the cell bodies in here. Well, actually, the cell bodies are not in here. The cell bodies for the sensory are out here in the dorsal root ganglion, but the spinal nerve associated with that comes in to go into the back of that, of the spinal cord through the dorsal root. Okay, and then now in this case, in the motor plate, you have the anterior horn cells here that grow their axons out and go to the myotome to supply the muscles, okay, of that are associated with that specific spinal nerve. Especially the sensory part of this peripheral nervous system, that is actually, see this little blue area here? These are the neural crest cells. The neural crest cells actually are what end up developing the peripheral sensory neurons in that dorsal root ganglion. That's what forms those. Where in the motor plate, the motor neurons develop and grow out of the actual gray matter there and then extend their axons out to the myotome. Okay, but the neural crest cells here are where the cell bodies for the dorsal root ganglion come from that are going to make the neurons, the peripheral sensory neuron component, and contribute to that. This is a little further on in development here. So, here's your somite that is becoming much more differentiated here. And, here it's forming the dermis of your skin and the associated dermatome. Here is this is going to develop into the myotome or the skeletal muscle. And then the sclerotome here is actually forming, you can see the vertebrae, okay, and developing that. And then eventually the ribs that are associated with each of those as well. Autonomic nerves come from here as well. Autonomic neurons those are also part from the neural crest cells so they're involved with the peripheral sensory nerves, but also the peripheral autonomic nerves. So the 3-vesicle, 5-vesicle stage and how they correspond to mature nervous system. So I handed you out that little diagram on the back of those things that it's probably a little better for the way we probably want to look at it. Here's another picture here that's more color-coded, which is sometimes nice to see. So we're talking, this is a 3 to 4 week embryo right here. And so this is looking at the side of the embryo. It's actually, kind of curled like this. But so what we've done is kind of like taken it, uncurled it, and cut right down through the front of it like a, frontal cut through there. And right now it's still kind of a hollow tube essentially. So there's space in there, this hollow tube. You haven't developed the nervous system and kind of grown all those structures out yet. So you start out with what's called the 3-vesicle or primary vesicle stage. And that's considered the prosencephalon, mesencephalon, and rhombencephalon. Okay? And that's forebrain, midbrain, and hindbrain. Okay, your book just talks about forebrain, midbrain, and hindbrain, I think, in that 3-vesicle stage. Then you end up moving towards what's called the 5-vesicle stage, and you get further development. So the prosencephalon differentiates into the telencephalon and the diencephalon. And then the mesencephalon stays mesencephalon. The rhombencephalon divides into the metencephalon and the myelencephalon. So that's how you end up with 3 over to 5 vesicles there. These guys get confusing, but it's nice that they actually are in alphabetical order. If you look mes, met, my, so that helps me remember where we go from top to bottom is mes, met, and my. Now we look at the actual adult derivatives. So this last thing is, so the telencephalon eventually becomes the cerebrum. So what happens is this telencephalon, as it grows, the cerebral structures kind of grow out this way and starts dropping down. And this little area here, this little thin layer of tissue here, this thing fills in and that grows to develop those big cerebral hemispheres. Okay, and so then right now in this case the space is really big. The ventricle system essentially takes up most of the space, but as the neurons grow, they become a much bigger portion of the nervous system, and then the ventricular system becomes a much lesser part of that because you're growing the actual tissue mass, the nervous system, out from the little thin layer there initially. Okay. There's little eye cups that are going to form your eyes. But here, see the diencephalon? It's considered, the thalamus, hypothalamus, and epithalamus. And you could put subthalamus in there, but, different books, this is the most common, is probably those 3 big structures there, the thalamus, hypothalamus, and epithalamus. And some will just say thalamus and hypothalamus. And then the mesencephalon stage is the midbrain. Okay, and then we have the metencephalon becomes the pons and the cerebellum, and the myelencephalon becomes your medulla. Yeah. Yeah, see, so sometimes they'll put the neurohypophysis in there, the pituitary gland. Yeah, so I wouldn't trip you up on a question that makes you, if anything, it would be something like, if we're talking diencephalon, I'm going to stick to thalamus and hypothalamus so I don't confuse you guys. Yeah, but thanks for clarifying that. Different resources or sources will talk about them differently. So anyway, so that's just kind of what to understand that. So because sometimes you'll read a book and they'll actually refer to, even in an adult, they'll say the whatever the whatever cranial nerve something is mesencephalic structure, and you're going, what does that mean? This cranial nerve is a mesencephalic structure. It just means that that cranial nerve happens to be in the mesencephalon, in the midbrain. That they just mean midbrain. So occasionally you'll be reading through a resource or a text or a research article, and they'll refer to something as like a mesencephalic structure, okay, but they wouldn't say telencephalic, but the most common is mesencephalic, because since mesencephalon stays midbrain, that oftentimes people will still call something that's in the midbrain a mesencephalic structure when you're reading about an adult, fully developed nervous system. So, okay. All right, 3rd month in utero, the great rate of growth of the vertebral column exceeds that of the spinal cord. Give a few clinical reasons why this is significant. And I heard you actually were talking about something I didn't have on this list, so I'll talk about it. I heard you guys talking, so good job. So a clinical significant part of that is that means the spinal cord actually ends at L1, L2. Our spinal cord does not go all the way down to the bottom of doesn't go to our sacrum. So there, from another clinical, interest in that, because of that, is that there's a space down there, and actually there's a pretty big space, but you have these peripheral nerves that are coming off the end of your spinal cord, that cauda equina, but there's a pretty decent amount of space in there still, so you can insert needles and do epidurals, and you can get cerebral spinal fluid with less risk of, you're not going to hit the spinal cord, okay? Now you can nick, and run into one of those little nerves, those spinal nerves from your lumbar spine that are coming off of there, and get some damage temporarily. So if somebody goes in, they get a spinal tap or something like that, or an epidural, there's a chance if they nick one of those nerves, you could have some referred pain for a while. Most of the time it repairs itself. You don't pierce right through it. It kind of moves out of the way, but you might hit the side of it, damage some of the Schwann cells or the myelin on that nerve, and it gives you some paresthesia, some pain that takes a few months to recover from. So that's one of the, not contraindications, but side effects or complications of epidurals and those kind of things, and spinal taps. If you have an injury to your spinal column below that L1, L2 level, it's not a spinal cord injury. If a spinal cord injury, you can only damage the spinal cord above that L1, L2 region. Okay, so that's going to lead to, there's a specific name for it called cauda equina syndrome. So anytime you have somebody comes with a broken back or some damage to the spine below that L1, L2 level, they're going to have what's called more of a cauda equina syndrome, which can be weakness, motor loss, and sensory loss below that area of lesion there, so below those L1, L2, spinal segments. Often it tends to affect more the sacral area, so they have kind of the saddle area and where their sensory is lost, and they have bowel and bladder flaccidity. Their muscles don't work in their bowel and bladder, and they have a flaccid bowel and bladder, which is actually worse than a spastic bowel and bladder because you can't control it at all. And so that's called a cauda equina syndrome. It's a lower motor neuron problem. You've damaged the motor nerves and the sensory nerves that are coming off the spinal cord versus you didn't damage the tracks or the pathways going down to those nerves in the spinal cord itself. Okay, so that's the difference in the type of injury. And when we get to the motor system, we're going to go through why you have these different presentations with lower motor neuron versus upper motor neuron problems. Okay. And then injuries above L1-2 cause upper motor neuron symptoms. Hamza was mentioning about the, I think, tethered cord syndrome, weren't you? Were you talking about tethered cord syndrome? So that's another thing that can happen clinically. Is it's not all that common, but if your dura or something gets stuck to one of your vertebrae as this is happening, that since the vertebrae are growing faster than the spinal cord can elongate, and you get something adhered abnormally. Now, you normally have that little bit of pia, that filum terminale off the conus medullaris that goes to your sacrum, and that thing stretches pretty good and elongates and doesn't cause this tethered cord syndrome typically. It can, but it's usually like your dura or something gets adhered abnormally to one of your vertebrae. So as your vertebrae are growing, it's stretching and pulling on that spinal cord because it's not growing as fast as those vertebrae are growing. And that can then basically traction the spinal cord and stretch. And it's going to cause more upper motor neuron type problems. It can cause spasticity and tone in the legs and the lower body typically. Can cause some bowel and bladder issues. And cause pain. If it's a real mild case, I've had, you have patients, it's kind of like the same thing. It's called, have you had somebody that has a positive straight leg sign when like you have a bulging disc and the disc is bulging back and it's actually bulging so much that it might actually hit into the dura and spinal cord. And so when you flex the head and you straighten their leg, you're pulling on the dura, and because the dura is being pushed on by also the disc, it tractions the spinal cord a little bit and can cause like those symptoms of radiating pain or shock-like pains up and down your spine. It's kind of like kind of a tethered cord syndrome in a sense. But it can happen in development of the nervous system, and somebody may not notice it until they get into positions where, man, my hamstrings are always tight. I never can stretch out, and if I tip my head down, I get this kind of shock-like sensation up my spine. That could be a tethered cord syndrome, but it also could be MS, so multiple sclerosis also, because when you have lesions inside of your spinal cord, and you can, if you really tip your head down, raise your leg up, bring your toes, you can traction your dura and your spinal column cord a little bit. And if you have any kind of scarring or lesions, that'll cause some of those shock-like symptoms too. So just depends, So that's something though to be checked out if you notice that in a patient. So that's just demonstrating that process there. All right, based on understanding of neurodevelopment, why do motor function neurons with spinal nerves tend to be located more ventrally in the spinal cord and sensory more dorsally? Also, why do cranial nerve nuclei associated with motor function tend to be more medial and the sensory more lateral? So let me just show you a picture here. Kind of going back to that dermatome and myotomal type of thing. This is the developing neural tube, and it's differentiating into this basilar and alar plate. So alar and basilar plate, or also known as association and motor plate. So your cell bodies for your motor neurons are going to originate here. So that makes sense why motor features, and those are going to end up being your anterior horns in your spinal cord, and then these are going to end up being your dorsal horns. And we know the sensory comes in the back here, so dorsal in the spinal cord is sensory, and these ventral horns are motor. That's why the more ventrally located in the spinal cord is the motor system. Dorsally is the sensory system. If you think of your spinal cord into your brain stem as a continuous tube, and it's continuous in nature, but what happens when you get up into the brain stem and up into where the cranial nerves lie? Your cranial nerves are kind of like spinal nerves, but they're coming out of your brain stem or your brain. We're talking about the ones that come out of the brain stem. The cranial nerves that come out of the brain stem. They're like cranial nerves, but they have some motor function, they have some sensory function, they have some autonomic function, but they also have some of these special sensory functions, okay? They're a little different than your typical spinal nerve. As opposed to them staying like in the spinal cord, all the motor neurons stay grouped in this long column of motor neurons that stay uninterrupted all the way down your spinal cord. And they just have motor neurons going out the different spinal levels to go supply the myotomes, okay? Same thing with the sensory system in the spinal cord that stays a long column of cells associated with your sensory system coming in the back side of that. Once you get up into the brainstem, that column of cells doesn't stay so, together. It starts to break up into these individual nuclei, okay? but it does tend to stay in a certain arrangement. They tend to stay closer together. And so what happens is, as you get up into the brainstem, what happens is the back of the brainstem gets kind of almost like filleted open, like a butterfly open, because the cerebellum sitting off the back where the pons and medulla are, as the cerebellum grows and there's that fourth ventricle in there, it makes your back of your medulla and pons kind of like fillet out like this, okay? And that's what this is kind of showing here. So the back part of your brainstem starts to open up and get flayed out this way. And so what happens is, so all the motor things that were here in your spinal cord, they stay more medial and break up into these individual cranial nerve nuclei. And then the sensory areas, or sensory neuron type areas, they move more laterally, because this back here, this is your fourth ventricle. Your cerebellum is sitting back off here, off the back. This is a cross section through the medulla, the very top part of the medulla, okay? The reason I point this out is because this is just good stuff to know, because when we get into the brainstem and you see a cross section of a brain and I'm telling you what is this structure right here, and you have a list of items and 2 of them are sensory cranial nerve nuclei and 2 of them are motor, you just narrowed it down to a 50-50 chance, because you know it's probably going to, if I'm pointing to a very medial structure in that cross section, you go, I know it's got to be a motor cranial nerve, so at least I'm going to guess between these 2. I know it can't be sensory. Sensories are going to be way out here laterally, okay? So that's just why those are some important things. And also when we start talking about lesions to the brain stem, if the lesion is way out here in the lateral medulla, it's going to cause more sensory issues. If the lesion is more in the medial medulla, you're going to have more motor problems of motor cranial nerve nuclei. Does that kind of make sense? So this cross section right here, this is a horizontal section, and this cross section is actually right through this area here, and you're looking down on the top of this horizontal section here. And so this is your fourth ventricle. That's this area back here. This is your fourth ventricle, that space, and your cerebellum is sitting back here, and so the cerebellum's been cut off here, and we're just looking down at the top there, and this happens to be that little area there, this pontomedullary junction. This is the medulla here, and then this is the pons up here. That's a messy area. There's a specific scary brainstem cross section there that has lots of cranial nerve nuclei and structures there that, but if you kind of have some basic understanding that the ones that lie more medial are going to be more motor, the ones that lie more lateral are going to be more sensory in nature, okay? Fun stuff. All right, development of the nervous system. We get through this. I forgot I left this picture in here. This is a picture. One is me, and one is my son. So you get to guess which one is me, which side is me. Left. Does the picture just look older or something? And the lazy eye. Do I still have that lazy eye on the left, or something? A little disoriented look. We were definitely like the type of kids only a mother could love, at least for that. That was day one. That was literally like hours after birth. At least I'm hoping that was for me. So let's talk about developmental stages in utero. This is going to kind of coincide maybe with some of the things you're learning in maturation science. Have you guys talked about any of this at all in maturation science yet? But we're going to focus primarily on the nervous system. So we're going to just talk generalities first, then dive into the nervous system. So we're going to talk about some different stages of development. So we're going to talk pre-embryonic. This is just first 2 weeks, conception to 2 weeks. You get that solid sphere of cells that are formed. A little cavity opens up in that, and that now it's called a blastocyst. The blastocyst then implants in the endometrium. You develop an inner cell mass that is going to be your embryonic disc that's actually going to become the embryo that starts out a little disc. Initially, that disc has just 2 layers, an ectoderm and an endoderm, and then eventually that third layer forms between the other 2 layers. This is all happening within the first 2 weeks. So that's just showing you on the left that process there. This is where it turns into the blastocyst right here once this space opens up. And then eventually that inner cell mass develops into first just 2 layers, an endoderm and ectoderm. this is where I was always confused, and it took me a while to figure all this out. But this is this space that's opening up above here. This thing is going to continue to expand, and eventually this embryo is going to move up into that, and that's the amniotic sac. Okay, so the embryo is going to go up in that amniotic sac. This area down here is the yolk sac here, and that's eventually going to be like absorbed up into the embryo as part of the gut, kind of in the area. So this is showing you now on the other picture is more of a sagittal section through the embryo, is just this little blue looking disc here. This is kind of the embryonic disc here. And then as it starts to develop, you see this amniotic sac kind of grows, and the embryo becomes inside of that amniotic sac, and then here's that yolk sac that eventually gets absorbed up into the embryo. Okay. So now let's go to the embryonic stage, which is 2 to 8 weeks. This is where we have the ectoderm that starts to differentiate into sensory organs, the epidermis, and the nervous system. So here's key. Ectoderm, nervous system. All of your nervous system starts from the ectoderm. Okay. All of your nervous system comes from ectoderm. And then we have the mesoderm, which is going to be your dermis, muscles, skeleton, excretory and circulatory systems. Then the endoderm, gut, liver, pancreas, respiratory systems. Just another picture showing kind of, this is during the 5th week of pregnancy here. This is that amniotic cavity or amniotic sac. Here's the embryo. This is the yolk sac. We're starting to see the somites form, starting to see these edges of the neural tube getting close to each other to touch. And then fetal stage is everything after that first 8 weeks. So after the first 8 weeks, you're in the fetal stage. This is now the nervous system. If we're just talking about the nervous system, it starts to develop more fully, and we start to then get myelination. But full myelination doesn't occur until you're almost age 3 or so. First 2 to 3 years of life, you don't have full myelination of your nervous system. So formation of the nervous system, development of the neural tube and brain. We're going to specifically focus on the neural tube and brain. Okay, so neural tube formation happens right around day 16. A lot happens in these first, few 3-4 weeks of life. The first month is really, really critical, and that's why there's such a, this emphasis on prenatal care. Developing a nervous system, a normal nervous system, everything is really critical that first 30 days. So it's knowing that you're pregnant and not doing things that harm your embryo and all that stuff is really important. And a lot of the reason if somebody miscarries is because of some kind of a malformation of the nervous system is one of the main reasons for miscarriage. So you start to develop this thing called a notochord as the first thing that starts to create this process or induce the process of starting to develop the neural tube. You got to develop this notochord, which is a slight differentiation of cells, okay? And that notochord is in the mesoderm. Remember I said nervous system's from the ectoderm, but the notochord kind of gets the process started. It's not part of your nervous system. Your notochord actually is as you're an adult derivative, it actually becomes your nucleus pulposus in your middle of your vertebral disc, little gum-like center or whatever, jelly-like center of your vertebral disc. That's leftover notochord. Okay, that's what used to be your notochord, but that's not a nervous system structure. Okay, but it starts the process that signifies to the nervous system, hey, start to thicken that ectodermal plate there and start to form. Okay, and it defines the longitudinal axis of the embryo. Completed by 4 weeks, and that initiates the process of what's called induction, which is where you start to get the ectoderm to fold in on itself. It's kind of like the notochord's like a magnet that draws it down to start to form the groove, the neural groove, which becomes a neural tube. Okay, and we'll show you a picture of that in a second. And then, like I said, the notochord ends up being your nucleus pulposus in the mature intervertebral disc. So I guess if you told somebody you've got a bulging notochord, it'd be technically kind of correct, but they look at you, what the hell are you talking about? A bulging notochord? Yeah, it's just your nucleus pulposus. So here we're looking at a picture. This is looking through, a horizontal section through an embryo, but we're just looking at the back of the embryo here. So the embryo would be, like this, but we're just looking at the top and back of the embryo, right across the top of the back, the dorsal area of the embryo. But here's the notochord forming. And once that notochord forms in this mesoderm, that tells this ectoderm to start thickening up and starts drawing it in like that to form this neural groove, okay? There's a little cells that are right on the crest of this neural groove here that are going to become the neural crest cells, okay? And those neural crest cells eventually move in here. You'll see down here. But here, now the notochord continues to facilitate this process of induction. The groove gets deeper. Eventually, these two sides touch. Okay, when they touch, that's now when you've got the tube formed. Okay, and it touches kind of in the mid-upper thoracic region, and then it zips rostrally and caudally like a Ziploc bag. Okay, but it touches kind of in that mid to high thoracic area, then zips rostrally and caudally. Okay, once those neural crest cells touch, they divide and move into the mesoderm. They still came from ectoderm, right? And this is what's going to form your dorsal root ganglion and your peripheral sensory nerves, okay, that are going to be associated and go to the dermatomal region of the somite, which they don't. The somites would be right in here, which they don't show. They don't show the somites, but the somites would be right in here, and they would kind of divide into their three different parts: the dermatome, myotome, and sclerotome. Day 16, this is looking, here's a view where you're looking straight down at the top of the embryo, and you're starting to get this thickening of what's called the neural plate. And that neural plate is formed out of that ectoderm, okay? There would be a notochord right here, starting. They don't show it here, but that's what starts to get that process of this thickening up, and then eventually starting to draw it in and start that process of induction. And then we get the neural tube formation. So right around day 18 to day 26 is when you get the neural tube formation. Longitudinal thickening of the ectoderm, the edges of the plate fold to create the neural tube. When the edges touch, the tube is formed. Day 21 is when the tube is actually, when that's the time that they first get the, meeting of the neural tube. Yeah. It really is pretty darn consistent, because when you're talking, this is a tight span, and it happens, I'm sure there's sort of a little variation, but for most people it happens within that day period. Yeah. I don't try to get you guys too tripped up on some of these time frames, but you should know some general, like a lot of this stuff is all happening in the first 30 days, and you should kind of know when the big differentiation is like pre-embryonic, embryonic stages like that. But if I give you a multiple choice, I'm going to give you numbers that if you know the ballpark number, you should get it. Does it happen on day 50, 6 months, 21 days? You're gonna be like, I know it's not 50 days. I know it's probably not 20 something day. I'm not going to give you, is it day 21, day 22, day 23, or day 24? I don't, but some professors will do that. So I'm not that person that does that. So you're PTs. You're not OBGYNs. Tube closes first in the cervical region, right? That cervical thoracic area junction, and zips rostrally and caudally. Cells adjacent to the neural tube form the neural crest cells. The neural tube moves inside the embryo. The superior neural pore closes around day 27, and the inferior neural pore closes 3 days later. So that's day 30. So that's the key, is that the first 30 days, to get that neural tube developed and get them to close right on each end, all that happens in that first 30 days. If that doesn't happen, it's all right. Didn't sound like it had anything in it, really. Because I said if it does, you better be picking. Just sit there leaking out. And then eventually that neural tube differentiates initially into this mantle layer which is going to form your gray matter, and the marginal layer, which becomes the white matter of the spinal cord. Okay. That gray matter then is going to eventually further differentiate into that alar plate, basal plate, motor, sensory areas. Okay, that gray matter. And that's about day 26. And again, some of those exact days are not as important as just kind of knowing a lot happens in that first 30 days. So this is showing you some pictures from your book, showing you those different top view of the embryo to this horizontal section, thickening here, the groove is formed. Here's the little neural crest cells starting to differentiate. Here's your somite. Eventually, day 21, you get the neural tube forming in that cervical thoracic junction region. Neural crest cells move in. They were the ones that touch together there. Then they kind of break apart and move into the mesoderm. And then you have your neural tube forming here. You can see this zipping going on rostrally to caudally. And then about day 26, now that neural tube starts to further differentiate into the gray matter and the white matter. And remember, like in the spinal cord, our gray matter's in the middle and our white matter's out on the outside. And that's how it started, with that gray matter in the middle, that mantle layer, and that marginal layer, the white matter, is on the outside. Just some electron microscope pictures of that same process. This happens to be in a chicken embryo, but showing you the neural groove and tube formation. So relationship of neural tube structures to other developing structures, we've already talked about this, the sclerotome, myotome, and dermatome, those differentiating cells within the mesoderm, the somites that are in the mesoderm. That mantle layer we talked about, eventually those cells, the mantle layer cells proliferate and separate into a ventral, motor, or basal plate. So it's the motor plate or the basal plate. You can use those somewhat interchangeably. Some books will call it basal plate, some will call it motor plate. And then the dorsal part, back part of that gray matter, becomes the association or alar. And I think association or alar with afferent. They're all A's, whatever. It's association, afferent, alar. It's a sensory structure. Okay, it's a sensory area, gray matter in the spinal cord. Neural crest cells, we already talked about those. Those break into segments also that form, eventually that's forming your dorsal root ganglion and your sensory nerves that go to the dermatomal regions, connect the spinal cord area development to the dermatonal area on the somite. The neural crest cells are what are making that nerve, that dorsal root ganglion cells, and their axons that come off of it. They also develop myelin cells, the autonomic, peripheral autonomic, and some endocrine organs. Okay. So we've already seen this picture. Here's brain formation, begins day 28. So after the, right at the time it starts to begin, right at that 28-day region, you start to develop the brain structures. So here's day 28. When you start to get right around that time is when that neural pore closes, that rostral neural pore closes, and you have your prosencephalon, mesencephalon, and rhombencephalon. That's the 3-vesicle stage here at day 28. Also forebrain, midbrain, and hindbrain, and then you move to the 5-vesicle stage, and then eventually to your adult derivatives, which is still, once you get to, this is 100 days here, you're kind of now got your nervous system differentiated into what it's going to eventually be as an adult. Okay. From a standpoint of the cellular level development of the nervous system, you have these epithelial cells that line the neural tube and divide to produce the neurons and the glial cells. The neurons differentiate appropriately after migrating to their final location. Okay, so and the neurons find their target by testing the chemicals with this thing called a growth cone. Then they make neurons that don't make appropriate connections die off. And that's why, again, that first few months, few years of life are so important to develop good connections within your nervous system, because if you don't develop those good, strong, diverse connections, then they die off and you never have those again. So that's why that enrichment kind of stuff, those first 3 years of life, is really, really important. And you get some neuronal sculpting. This is a form of neuroplasticity. Axons will retract or grow and be kind of like trimmed or shaped based on use. Okay. If we go back to all the way to the beginning here, I don't know if I've come on. So if you look at this 5-vesicle stage, there's neural epithelial cells that are on this most inner layer right here. Those are kind of like your neural stem cells, epithelial cells. That's where they start to grow from. And they migrate out to the periphery, and they layer on top of each other like an onion. So these neurons start in those little epithelial cells, undifferentiated. They know they're going to be neurons, but they don't know yet exactly what kind of neuron they're going to be yet and where they're going to be located. And so as that cell grows, it extends out this little growth cone, and it starts testing the area that it's moving into, as far as looking at just kind of what's going on in that area, as far as the molecular makeup and what, then it senses which way it needs to go and which way it needs to grow, and then plant itself into that region. And then, because of other cells that end up nearby it, help it to differentiate and realize what it's supposed to do, and then make connections and so forth. So it just kind of builds on itself. That's kind of how you layer this, especially in your cerebral structures. But it happens in your cerebellum, it happens in the brainstem and spinal cord as well. Myelination begins in the 4th fetal month, occurs at different rates in different systems. Most myelination done by age 3. Sometimes you don't know a child's going to have a developmental deficit until after that age 3, because kids are still maturing, and they grow into the deficit, because they start not hitting milestones, because they're not getting full myelination, or you're not noticing something, they're not hitting those developmental milestones. So sometimes it takes a while when they start hitting some, and then all of a sudden they're not hitting other milestones, and you realize something's going on here. So they maybe have a developmental disorder of some type. Also, so the Babinski sign is when you scratch the bottom of somebody's foot. In an adult, your toe points down and your toes come together. The other 4 toes kind of come together. It's just a little brief thing, but they do this, In a baby, okay, that's, in less than 3 months old, you do that, their big toe is going to do this, and their little toes are going to splay out like this, which in an adult, that would be an abnormal response. Part of it's because of myelination. And as your nervous system gets more myelinated, then you don't have the Babinski response. So that's why in an adult, when you damage the nervous system, especially it's an upper motor neuron problem, you're damaging something in the spinal cord or something like that, it's almost like you're, in a sense, demyelinating it you're not really demyelinating it, but you're damaging it enough that you no longer have that normal response. And you would get this, we don't know why it does that, but that's why you get the great toe extending. But in a baby, that's normal. So if you scratch the bottom of a baby's foot, and you go, as long as they're, 3 to 6 months, if they're a couple years old and you do that and they have an abnormal response, then they probably are, a child with cerebral palsy or something like that you're treating. This is a good time to take a real quick break here, and then we'll come back and finish things up. Any questions? All right. Developmental disorders of the nervous system, and this is something you probably hit on in your maturation science when you get into pediatrics. I'm not going to spend a lot of time, but Let's talk about neural tube defects. One neural tube defect is this thing called anencephaly, and it's that formation of rudimentary brainstem without cerebral hemispheres or cerebellar hemispheres sometimes. Occurs when the cranial end of the neural tube remains open and the forebrain then doesn't develop fully. Okay. Most fetuses die before birth, and almost none survive more than a week after birth. So, yeah, nobody lives, longer than a week or two with this condition. So, this is pretty severe form here, and you can see on that side view there, this is that malformed rudimentary kind of brainstem area that does not actually have a cerebral hemispheres, and there's no cerebellum off the back of that either. So, okay. Another neural tube defect, Arnold-Chiari malformation. Although I don't know why they call it a neural tube defect, but it's really more of a defect in your foramen magnum, but also I guess it could be partly due to some of the neural tube problems. But anyway, the inferior cerebellum and medulla are elongated and protrude into the vertebral canal through the foramen magnum. So you've got the medulla and then the cerebellar tonsils, we call them, kind of pushing down and leaking down through the foramen magnum, and it can create some pressure there and actually can block cerebrospinal fluid flow too into that region. Okay. It can be associated with hydrocephalus, because if you're blocking those spots under your cerebrospinal fluid gets out into the flow around the outside of your nervous system, right at the bottom of the cerebellum. There's three little holes there. If your bottom of your cerebellum is getting squeezed down through your foramen magnum, you close off those holes. So you get a backup of cerebrospinal fluid into the lateral ventricles, third ventricle, fourth ventricle, and that just causes then the head to swell because there's nowhere for it to go, so it just keeps growing. But in a baby, your sutures aren't fused yet in your skull, so it can just accommodate for that, but it's still not good. It's not a good thing to have happen. The other thing that can happen for more mild versions, if you don't have hydrocephalus, is it can lead to just tongue weakness and facial weakness and deafness, and also weakness of lateral eye movements, because this is where a lot of cranial nerves come out, right at that medullary pontine junction where the cerebellum's sitting off the back. So if the cerebellum and the medulla start to slip down through the foramen magnum, those cranial nerves that are right there that come off, can get pushed on, squeezed, mangled, and can cause these problems with cranial nerve function in that area. This is a picture showing this. There's little green dots here. You can kind of see here, but this is where the foramen magnum is. You should see none of this down here. That should all be above there. So these are the tonsils that have slipped down, and you almost see this, what's called almost like a herniation of the medulla back here. But your skull is right there, so this stuff gets squeezed down in there, and then there's a lot of cranial nerves that come off right in this region here. And so as they're coming off there, they can get squeezed in that foramen magnum or tractioned, or so that's where a lot of those cranial nerves come off. Okay. What they can't, they might have to try to come in. Sometimes they'll actually open up that foramen magnum more and give more room for things so that things aren't getting pushed on. Or if they can, I guess they can kind of, if it's not too bad, they can push it up and then take a bone graft and try to close it down so it doesn't slide through there as much. So there's actually a third-year student right now she had a Arnold-Chiari malformation that was recognized later on in life. She had severe headaches and all this kind of stuff, and so she had to have a repair done for that. So if you do end up with some swelling or hydrocephalus because you've got some backing up into the lateral ventricles, they can do a shunt. And if this is a shunt where they take this small little tube, and they know certain regions of your brain that you're not going to knock out function, and they slide it right through your brain into the lateral ventricle to allow cerebrospinal fluid to leak out through that tube, and it runs right underneath the scalp, under your skin, down your neck, underneath your clavicle, and then down into your peritoneum, and it just dumps the cerebrospinal fluid down there and gets your body recycles it. And So that's a shunt. And if you've worked with patients, sometimes I've had orthopedic patients where I'm palpating and I go, what? That doesn't feel like a tendon, or oh, I've got a shunt. And then you go up on their scalp and you can feel this little button right here kind of sticking out, where then the junction point where it goes from the metal tube into the the plastic one that runs down in there. So you can still work with those patients. They can still do everything. You just don't want to be, you got to be a little careful. I want to be careful of manipulating their neck or doing soft tissue massage to their scalp or anything that I don't want to mess with it too much. But the shunts can get clogged is the big thing, is you get protein deposits in those, just like your arteries get clogged, these shunts get clogged. And oftentimes you have to replace shunts and they can get infected. And the more times you keep sticking shunts into somebody's brain, the more chance for complications and damage and those kind of things. So and it can be an issue. So.
Is it like pressurized, or how do they, like once you puncture the vesicle, how is it all this fluid not just go down?
It's kind of neutral, the pressure there. There's not a lot of pressure, so it just, whatever's left over, it gets pushed in there, so it still allows it to circulate. I don't know exactly if they can adjust anything on how open or closed that is to adjust the flow, but yeah, good question. So, and you see how they have a lot of extra in here, so as you grow, it's not gonna be too short, so they leave a few extra feet in there, so as you grow, it hopefully doesn't get tractioned on, can allow it to continue to. Still on some neural tube defects here is spina bifida. So this is where the inferior neural pore does not close properly, can result in neural tube defect called spina bifida. There's different types: spina bifida occulta, meningiocele, meningiomyelocele, and myeloschisis. Meningi is your meninges, like your dura, arachnoid, pia. A myelo, that term myelo is spinal cord. It's not myo as in muscle, it's myelo is spinal cord. Okay, so this kind of tells you what's happening here, whether just the meninges are involved, or whether the meninges and the spinal cord are involved, or whether there's this myeloschisis, which will show you some pictures here. So this first one up here, from a good old Netter book here, this is spina bifida occulta. This is where you actually get failure of the caudal neural tube, but the meninges are mostly okay and the spinal cord's okay, but you just get this failure of the final vertebral levels, that vertebral arch, to close off and form properly. And so you've got this little deficit, and you usually get this like fatty infiltrate in there. So you see this little bit of fat in here, this fatty infiltrate. And oftentimes these people will have this little tuft of hair right there over that vertebral arch area, and that can be a sign that somebody has a spina bifida occulta. For many people, it doesn't bother them a bit. They'll never notice it, doesn't cause an issue. Sometimes I run across patients. Sometimes this will lead to some malformation of the facet joints too, and so they'll have some back pain related to this because there's some facet joint involvement and they don't have a fully formed vertebral arch there, and can cause some instability in their spine and so forth. So that's something just to look at. This has to be confirmed with x-ray. What this is showing, this x-ray here, so you see this x-ray, this thing is all nice and filled here. The next vertebral level down here, there's a gap right there. So I just there's a gap in the vertebral arch kind of right between this and between that. So you can kind of see that open space there. That's a spina bifida occulta. This is a meningiocele right here. So in this case, the vertebral arch is impacted, and then what you have is a seal. A seal is a fluid-filled sac, basically. So you look at the back of the baby, it's got this, bulging sac of fluid, and then in this case, this is the meninges, and in this case, it's just going to be the dura and arachnoid. The pia is still attached to a microscopic layer on the spinal cord, but the dura and arachnoid are out here in this space. You can see kind of the dura and arachnoid there, and then this is cerebral spinal fluid that's filling that space. Typically, the occulta meningeocele, this person's likely is not going to have any neurologic deficits, okay? Because you haven't involved actually any neural structures at this point. Now, if you get into what's called a meningeomyelocele, so now the meninges are involved right here, the outside, but now the spinal cord actually, this thing, and the vertebral arch is so large, the defect is so large that the spinal cord actually can enter into that space, and then here's the cauda equina, and so this is where you're likely going to have neurologic dysfunction and problems. And you'll see here that since the spinal cord's out here not being protected by bony structures, as the baby's moving around in utero, it can press on that sac and can cause some traction and damage to the spinal cord. And so now this is where they're actually doing some, surgery to babies in utero to fix this. As soon as they find it, to prevent damage, during the actual birthing process or during the pregnancy, is they're actually going in and doing some fixing of those lesions in utero, doing surgery in utero. Now this is a myeloschisis. A myeloschisis, and I think I've got a picture coming up. There's not really even a sac there. It's like this is such a large deficit, it's like almost filleted open, and you're looking right at like the spinal cord that's kind of been not even fully formed, the spinal cord, and it's kind of filleted open. It's called myeloschisis. A schism or schisis is like this gap or opening. Well, now it's no longer a seal. It's not a sealed thing. It's a filleted open thing, and you're seeing actual nervous system tissue there. So I don't have that. Not a great picture of that, but that kind of shows you that opening there, and you're looking directly at spinal cord tissue there. That's not formed that great even. So they're going to have definitely severe involvement of the lower body, the spina bifida. There's also forebrain malformation. This is where the prosencephalon fails to divide normally with varying degrees of facial abnormalities. The most severe is holoprosencephaly, failure of the brain and the midline structures of the face even to divide normally. These children don't survive. This is something they're typically born dead or shortly after birth, don't survive very long. It was interesting. I was reading a thing that said something about this sonic hedgehog gene is the name of the gene that's a mutation of the sonic hedgehog gene. So you just see some researcher who I guess must have played Sonic the Hedgehog when he was a kid or something and just say, I'm going to name it after that. So that's what you get to do if you find a new gene. You can call it whatever you want, I guess. So there's a very severe form of holoprosencephaly with the failure of midline facial structures to divide. And you would also see that in the cerebral structures. There would just be one big mass. There wouldn't be actually two cerebral hemispheres in there. It wouldn't be two sides to the cerebellum. It would just be, this kind of mass there. So. Exposure to alcohol or cocaine or any most illicit drugs in utero, fetal alcohol syndrome is pretty darn common, and you're going to see this sometimes. If you're working in peds, you're definitely going to see it. Impairment in the CNS maturation. It really dramatically can impact the maturation of the central nervous system. You see the growth deficiencies. You see these facial abnormalities, which I think I've got a picture on the next slide. And just some gross cognitive deficits. They're just a little slow, and they may be a little hypotonic, and they just don't have quite as good coordination. They've got these facial abnormalities that are pretty indicative of fetal alcohol syndrome. Cocaine abuse, that's going to cause problems with neuronal proliferation, so it's going to minimize or impact how good your neurons proliferate and divide and the robustness of that process. Cocaine can really affect the fetus because it does cross the placenta very easily, and it stays in the fetal circulation a long time. So here's kind of that classic. This is pretty classic of the fetal alcohol syndrome with kind of this, a gap here between the eyes, and the flattening of the facial features is very common with fetal alcohol syndrome. General intellectual disability. With significant intellectual disability, there's what they see when they look at the brains of these kids, the ones that pass away, as significant deficits in the morphology of the dendrites and then dendritic spines. And so all those dendrites, they just don't have as many of the dendrites, and also they just don't have the dendritic spines, so they don't have as many places for the good connections to develop. Okay, so it's a very common feature of intellectual disability. You spasm? You haven't spasm. Oh, did have stuff in it that time. Maybe I shouldn't have got you up this early in the morning. Cerebral palsy, I'm not going to go into not a lot of detail on these because, again, you're going to get this multiple times with Dr. Fillmore. It's a catch-all term to describe any non-progressive damage to the developing brain, typically due, for some reason, to diminished blood supply or oxygen. That could be a blockage of the umbilical cord wrapped around the neck. Could be a stroke, in the fetus while it's developing, as any kind of a stroke. Anything that's going to cause loss of oxygen, blood supply temporarily to the fetus that leads to neurologic damage. Okay, there's different types that they call classifications. Most people are mixed, but there's spastic, where you have typically the damage is around the ventricles to the white matter, the descending motor pathways to the white matter. There's the descending in that internal capsule region. They have a lot of spasticity, high tone, motor, but cognitively they're usually pretty good. And cerebral palsy can affect cognition some, but a lot of people with cerebral palsy have pretty normal cognition. Athetoid, if they have the damages more around the basal ganglia structures, they can have this more kind of athetotic movements, athetotic movements, but they kind of like this writhing kind of movements, this dystonic movements. It's not as spastic in nature, it's more kind of writhing and incoordination kind of thing, but it's more this kind of, snake-like writhing movements, athetoid movements. Okay. Ataxic is they have a lot of coordination deficits. It's different. Athetoid movements are kind of like these writhing, dance-like movements, where ataxic, as they move, they start to have a lot of deficits, and it's kind of in this, and the closer they get to trying to do something like reach for an object, the worse it gets because they can't make the error corrections, and the closer they get, the worse that the ataxia gets. That's damage to the cerebellar structures. And then the most common is some kind of mixture of those. So you could be a spastic athetoid, or you could be an ataxic, athetoid, varying degrees depending on if the lesions are involving multiple regions of the brain or cerebellum. So summary of developmental disorders, most of the major deformities of CNS occur before week 20, but we know that this first month is really critical, okay? More minor and localized damage may occur after week 20. 75% of spontaneously aborted fetuses are due to CNS malformations. Some things about nervous system changes during infancy are some critical periods during development when axons are competing for synaptic sites. Proper stim at this time is very important. So when you've heard about these kids in these Russian orphanages and those kind of things that got very little stimulation or appropriate, structured types of stimulation during those first 3 years, people bring them over, adopt them, which is awesome. But some of those kids, just will never fully develop, and to be very functional because they miss that golden window. Doesn't mean you don't get some continued ability to develop good connections and so forth. It's just much harder once you miss that window of develop the initial dendritic trees and arborization and connections if you don't have that initially. So, all right, we are done. Let me stop this.